Hello, my name is Dr. Karan Log, and I'm a cancer specialist in Colorado, and thanks again for watching Cancer Logic. Today what I'll be talking about is the different types of hormone blockers we use to help treat patients with breast cancer. So in previous videos, what I had talked about was I talked about the importance of having what we call estrogen receptor positivity, progesterone receptor positive, and what we know is that if you have expression of the estrogen and progesterone receptor, what you can use is a set of drugs that block that estrogen to help block and stop the breast cancer from growing. And so the hormone blockade is typically used at the end of treatment. So that's after surgery. Some patients may still need IV cytotoxic chemotherapy. They may need radiation. And after that, they would then utilize this medication or set of medications called hormone blockers. And so the first step that we use is basically determining whether or not a patient is pre or postmenopausal. And so when patients are premenopausal, the way that they get their estrogen is by their ovaries, as their ovaries just generally spit out estrogen. When patients are postmenopausal, their ovaries are no longer making estrogen. But what your body does make is it makes low levels of testosterone. And then what happens is in the postmenopausal female, your body will then take that low level of testosterone and convert it to estrogen using this enzyme called aromatase. Okay, so in premenopausal women, what we do is we use this medication called tamoxifen. And tamoxifen is in a class of medications called a SERM, or a selective estrogen receptor modulator. And so, again, it's really important to understand that because, again, it is a selective estrogen. So what it means is that it stimulates estrogen in some tissues, but then suppresses estrogen in other tissues. One tissue that it suppresses is the breast. And so, again, by decreasing the stimulation of estrogen in the breast, it basically stops and inhibits the production of breast cancer cells to no longer be stimulated, and again increase the likelihood that your disease will be contained with this hormone blocker. But because it can stimulate estrogen in other tissues, it does have a protective effect of stimulating estrogen and strengthening the bones. And so what we've seen is that if patients actually have weak bones, tamoxifen can actually increase their bone mineral density and health. But by also increasing and stimulating the estrogen, it can increase the risk of development of blood clots, or we call deep vein thrombosis, or DVTs. If the DVT then propagates and moves and gets lodged into the lungs, we then call that a pulmonary embolism. And so the stimulatory estrogen effects is very similar to patients who are taking birth control, where you're also at risk for developing blood clots with birth control, but the dosing and the intensity of the estrogen is less with tamoxifen, so the risk of development of blood clots is much higher in patients who take full dose birth control. But because it is an estrogen stimulator, tamoxifen itself can increase the risk of development of blood clots. As it also stimulates estrogen, it can stimulate estrogen and growth of the lining of a female uterus and increase the risk of development of uterine cancer. And so what we've seen is that in patients who are on tamoxifen, the risk of developing uterine cancer is still very, very small. The more important thing is that when patients are taking tamoxifen and they do develop endometrial or uterine cancer, what will usually happen is they'll develop vaginal spotting or vaginal bleeding. If that ever happens, they would recommend evaluation and typically even recommend a hysterectomy. But the risk of dying from uterine cancer while on tamoxifen is still very, very low because, again, there's a warning sign that we typically don't get with other cancers, and that warning sign would be, again, vaginal spotting or vaginal bleeding. So, again, in patients who are premenopausal, we generally recommend tamoxifen. But now, again, we go back to those women who are postmenopausal. And postmenopausal women, again, make their estrogen through this enzyme called aromatase. So what we actually do is there's a class of medications called aromatase inhibitors that basically block that enzyme from even making a little bit of estrogen. And so, what we've seen is that aromatase inhibitors overall are actually more effective than tamoxifen. But again, in patients who are making estrogen through their ovaries, aromatase inhibitors are not effective at all. So there is no benefit in doing aromatase inhibitors if you're premenopausal. But the other thing with that lack of estrogen, complete lack of estrogen with aromatase inhibitors, is it leads to a completely different set of side effects. And so by having that lack of estrogen now, what we see is that it actually can decrease bone mineral density strength and increase the risk of osteoporosis and developing an osteoporotic fracture. So we generally do recommend bone strengthening agents that we use for osteoporosis along with the aromatase inhibitors. But we also see a main side effect of when you lose the estrogen, you can actually develop a lot of joint stiffness and joint pains that come along with aromatase inhibitors. And we often do see patients where this becomes intolerable, where I've actually had patients tell me that it feels like they're just basically in a pool of water with just how stiff that they feel. And the joint aches and stiffness are often a very limiting and major side effect that we do see patients who are on aromatase inhibitors. But an advantage is that because you're decreasing the levels of estrogen in the patient, again, there's zero risk of development of blood clots, and there's also zero risk of development endometrial cancer. So again, just to summarize, in premenopausal females, again, they produce estrogen by their ovaries, and so the tamoxifen, or the class of medication, is a SERM, selective estrogen receptor modulator, blocks estrogen in the breast, but stimulates estrogen and increases the risk of blood clots, but also increases the risk of endometrial cancer, but has a bone protective effect. In terms of aromatase inhibitors, are only used in the postmenopausal setting, with the main side effect of weakening and decreasing bone mineral density, causing a lot of muscle ache and joint aches, but no risk of increasing the risk of blood clots or endometrial cancer. And so, again, hopefully that really clarified, why we use one agent versus another. Again, if you have any questions, feel free to provide any feedback or comments. Thanks again for watching Cancer Logic. My name is Dr. Karn Log. Hope you liked this video, and hopefully you found this informative. Appreciate any feedback you have, and thanks again for watching. Take care.